basically every other person that you come in contact with may have likely been exposed or is living with HIV, and that's including if they're unaware. Um, 72% of women that are diagnosed with HIV are Black. 1 in 7 Blacks in HIV are unaware that they have it, and people who do not know that they have it cannot take advantage of HIV care and treatment and may unknowingly pass HIV to others. So with that being said, I'll go ahead and introduce our panelists today. It's going to be an interesting discussion. I'm excited to see what everyone has to say. And I'll start off with Jay Shepard. Hello, Jay. How you doing?
Uh, Great to be here.
Great to have you. So Jay's pronouns are they and them. Jay is a 28-year-old Black, queer, non-binary, messy work in progress, passionate about the liberation and healing of all Black people. Jay loves twerking and staying hydrated, okay? Jay is an abolitionist organizer at Action St. Louis. Jay daydreams about the abolition of police, prisons, in a world where Black people should have resources not only to thrive, but to survive.
Next, I will be introducing our panelist, Devin Hursey. His pronouns is he and him. He is an advocate for public health and people living with HIV from Kansas City, Missouri. He is an appointed member of the CDC HRSA Advisory Committee on the HIV and viral hepatitis. His local and state level advocacy includes work as a peer educator at Truman Medical Center, serving as a board member for Blackout KC, and a member of the Missouri HIV Justice Coalition. Hursey also serves as a communication chair for the U.S. People Living with HIV Caucus, ambassador for the Henry Kaiser Family Foundation Greater Than AIDS campaign, steering committee member of Impact Global Action for Gay Men's Health and Rights. Thank you for Devin for joining us.
All right, and lastly, our last panelist is Jay Marie. Jay Marie's pronouns is they, them, and holy. Jay is a musician, a facilitator, and organizer from Oakland, California, now based out of St. Louis, Missouri. They run Music Freedom Dreams, a nationally oriented consulting and production house that specializes in freedom dreaming in the name of Black trans folk and Black women. They run the statewide trans justice program with the Missouri ACLU. You can find their music online under the name J-Maria's Holy, and more about their work at musicfreedomdreams.com.
We do have a discussion box available, a chat box. So feel free to put in any questions that you have in the chat box. And once the panel wraps up, we will have time set aside to answer those questions.
And just to echo Kaya, if you got questions, anything pertaining to today's webinar, feel free to use the chat box. We do have a chat a coordinator that'll be able to see those questions as well. All right, so we can go ahead and I guess dive into our question and answers, beginning with the statement I said earlier with the statistics that we were speaking about. And I'll go ahead and start with Jay if you're ready, Jay Shepard. So defining racial justice, the phrase racial justice has gained in popularity in recent years. Can you explain to us what this phrase means to you?
Yeah. Thanks again for putting this on Black Institute. Very, very happy to be here. Cat is being disruptive. But yeah, I define racial justice as the uprooting of historically racist systems and replacing them with just and equitable policies and practices that give reparations to Black folks for the centuries worth of harm and violence and disenfranchisement that Black communities have suffered and are continuing to suffer. I think that every issue is a racial justice issue because every issue touches the lives of Black folks. So gender justice is a racial justice issue because we know that Black trans women are most impacted by gender-based violence. Environmental justice is a racial justice issue because we know that Black communities have higher rates of mold exposure, lead exposure, asthma rates. We know that the criminal legal system survives off of criminalizing Black communities, off of over surveilling, patrolling, harassing Black communities, which has resulted in higher incarceration rates of Black folks. Yeah, there isn't a single issue that doesn't impact the livelihood of Black people. So I think thus every issue is a racial justice issue. And at Action, we touch on every issue because we know that it impacts the lives of Black folks. We have a housing justice organizer. We have environmental justice organizer. We have a campaign to close a jail. Also, we have a woke voter campaign.
Yeah. Okay, great, thank you. J. Marie, can you follow up with the same question?
Yeah, I mean, thank you, Jay, for that really holistic definition. I definitely would only echo that, and just to keep it even simpler, like, racial justice is the affirmation of what Black people deserve, right? And that means not just the, we hope bad things don't happen to Black people, right? But actually we have to do the work to replace and to retain, and change the systems and govern ourselves so that we can actually create the conditions that we deserve. That's all I would add. Okay. You covered so much.
Yeah. Thanks.
Okay. So my question is, HIV has been designated as a health issue, but can we speak to why we should be thinking more intersectionally about this? This question is for Devin.
Yeah, thank you. I'm not on mute, am I? Okay, perfect.
No.
So yeah, well, essentially HIV is a health issue if we look at it in its most simplest form. But what we know is that HIV incidence is really the result of a lot of different social issues. It's really a matter of who is not engaged and who is not at the table when a lot of these critical decisions are being made. And as a result, you can see who's most impacted. Oftentimes it's Black people, Black LGBTQAI people, and people fit into a lot of these different intersections. And then also I wanna add the point that HIV advocacy is a little bit different. We can see from the very beginning of the epidemic, people living with HIV and allies were really passionate about making sure that there was visibility brought to the issue, making sure that it's actually addressed. There was a day when, coalitions led by people living with HIV were spilling blood on the steps of Congress and, making all these various demonstrations. So I would say that protest is really in the DNA of our movement, but hope that answers your question.
Yes. J. Marie, can you answer this question as well?
Yeah, can you rephrase it one more time?
Yes, HIV has been designated as a health issue, but can you speak to why we should be thinking more intersectionally about it?
Yeah, so I mean, as Dev said, as Devin mentioned, it is a health issue, right? People think of it as just that, and we do have the legacy of folks who fought for us to be at these tables, for us to be in these conversations as Black folks. I'm not a person with HIV myself, so I definitely defer to those on the panel who are and who want to add nuance wherever is possible. But as a person who takes the legacy of folks who have fought for Black queer folks, Black trans folks very seriously, right? My work is to not only continue but actually elevate and kind of escalate the urgency of the situation, right? So, and I say that as somebody who is not only not a person living with HIV, but also somebody who is primarily intersecting in this work as like a trans person, as a person.
Yes, could I speak with Cynthia, please?
Oh, hey, what's up? Are we on the phone together?
Hi, Cynthia. My name is Leslie Wicks, and I'm calling from the Missouri Department of Health and Senior Services. And I'm calling up.
There we go. All right, awesome. So all good, it happens. You know what I'm saying? It's the Zoom age. So yeah, so as a person who is trans, as a person who is assigned woman at birth, like I have a very specific investment in this issue. And in my work in general, as the bio mentioned, I work at the intersection of how can I take care of folks who are both Black and trans and Black women, whether that means you're a Black trans woman, whether that means you're a Black queer person. I really look forward to kind of teaching folks about that intersection because similar rates befall whether it's HIV or sexual assault, similar rates befall Black trans folks and Black women. So that is an intersection I'm really committed to, and a big part of HIV advocacy at this point, right, is that Black women are left out of the conversation. Black trans women, Black trans folks broadly, many people have trouble getting care and access to care that they deserve. So if our AIDS service organizations and our HIV, activism advocacy is not rooted in the ability to speak comfortably and consistently about who is often left out, they're going to keep being left out. So we got to be committed to that work, before, after panels, do that reading in between, make sure who you're following is bringing these issues to the surface. And it really just has to be a part of how we move, right? So the intersectionality it just comes out at every turn, because we know that if we don't do that, they're going to keep getting left out, even though they're the biggest, folks are the biggest, needs, in the biggest need of care at these intersections.
Right, I definitely agree. You were speaking about how trans and Black women it's a little bit harder for them to have access to care and treatment. Can you elaborate a little bit more, J. Marie, as far as how racism impacts HIV risk and treatment, and furthermore, how racism impacts people living with HIV as it relates to Black women and trans?
Yeah, definitely. I mean, so what I think a lot of people might not think about, as Devin said, because people just think of it as a health issue, right? You might not consider that, unemployment, poverty, limited education opportunities, incarceration, voter suppression, housing instability, those are all issues that also disproportionately impact Black folks, right? So if you're walking in to get some care, right, and you don't have, your ID with you, or you don't have, like a piece of paper that might actually kind of confirm your healthcare, or whatever the types of kind of gatekeeping that tends to happen in some spaces, healthcare spaces especially, you're going to be left out of care, right? And on top of that, if you're trans and you're walking into a building that says they're there for people who live with HIV, but they haven't done that work to kind of deeply commit to that intersectional lens, they're going to be maybe misgendering you. They're going to be talking about things far beyond their range, because they haven't done that study in terms of what your healthcare needs would really look like. So that's what I would say. It's just a basic look at it, and I know that people on the panel can add more, but it's so varied, and we just gotta nix it in the bud at every turn, honestly.
Right, stigmatism is definitely rooted in that. Devin, could you elaborate a little bit more on that?
Can you repeat the question? There were pieces I didn't quite catch.
Sure. How does racism impact HIV risk and treatment, and how has race impacted people living with HIV?
So racism impacts HIV risk and treatment in some very simple ways. First off, when we're
when you going down to the neighborhood.
I'm sorry, please post the questions in our chat.
I'm waiting for Howard to.
I need someone to mute. Thank you. So I guess in very simple ways, racism impacts HIV. So for example, when we're designing grant deliverables, a lot of the times those deliverables need to be racialized. We need to make sure that we are testing the people that we know have the highest risk of HIV, and that shouldn't really be an issue. I've seen that become a point of a lot of debate on a local level. So we should recognize that it's really our job to correct a lot of these structural systems that are impacting various groups. And then when it comes to care and treatment, we just have to consider that a lot of the healthcare workforce is really incompetent when it comes to engaging with Black people. And the unfortunate truth is that as people living with HIV, we're very much dependent on that healthcare workforce to serve us. So when they don't know how to talk to us and we have to go and see them, I mean, there's a high likelihood that we'll just stop going.
Do you feel advocacy has anything to do with it, like lack of education, or just an access period?
So advocacy means a lot of different things. So in this context, we can keep talking about these things. We can keep educating. But I feel like there really needs to be some structural change. I feel like a lot of the times healthcare and public health only listens to public health. They've a lot of the times chosen not to listen to community because we've been saying the same things for a long time. We can continue to say those things, we can continue to guide them, but you know, public health is slow and we just have to wait for them to decide to listen to us.
Right. Yeah. How long we gotta wait? I'm sorry, Kaya.
I'm not making decisions, so I can't answer that. But there are people who are in these decision-making seats that you can ask that question to.
Okay, so how has COVID impacted how people of color and specifically Black people are faring within our health system? Devin, can you specifically speak about HIV?
Yeah, so how COVID is impacting people living with HIV, essentially, correct? Okay, so first off, I want to say that people living with HIV should be prioritized and should have been prioritized within the rollout of, you know, of the vaccine. But you know, another lens to use when we're talking about HIV advocacy is that this is really a conversation of disability justice, because you know, the larger public accommodations and people's own biases really impact what we have available to us in the way that we function through society, because this is a very stigmatized condition. So yeah, I was very afraid of getting COVID-19. And I was vaccinated, thank goodness. I had access to that. But yeah, I feel like we should have been a little bit more prioritized, and communities like ours should have been prioritized.
Okay, thank you. Jay Shepherd, can you speak about Black people and their focusing particularly on Black women and Black trans women? Same question.
Yeah, so we've seen that COVID-19 has disproportionately affected Black folks. Black folks are getting sick and dying of COVID-19 at higher rates than white folks. Black mortality rates for COVID-19 are 2.4 times higher than white counterparts. And I think it's a couple of things that really come into play around this is that most of our essential workers are Black women who are over represented in service industries, and it puts them in close contact with others. And some of these jobs, you know, aren't providing adequate PPE, and the Black women are also have higher rates of health disparities, which makes folks already immunocompromised. And also, like, Black women are frequently not listened to or believed by healthcare providers. And that's like the reality of our inherently flawed and racist healthcare system. Right now, COVID-19 is infested in our jails, which are disproportionate Black folks in our jail systems, right? And there was just, you know, a recent uprising this weekend where folks were demanding adequate COVID care. And instead of getting that, they've been grouping folks who are COVID positive with folks who are COVID negative, thus infecting more folks. And then when folks ask for PPE, they are met with tear gas. And yeah, right now we're witnessing like a really, really righteous anger moment from our folks demanding adequate COVID care in our jails.
Right. Yeah, I read something recently. I believe it was in a post from Missouri, or STL post, if I remember it correctly, that Missouri was actually one of the last states to even receive vaccinations. So that just goes to show some of the the imbalance and inequity that we are seeing in the state of Missouri. But Jay, just to expand on that a little bit more, what do you feel like policies are needed at a governmental or an organizational level to improve access to high quality healthcare in Black neighborhoods, especially those with that's infected with HIV?
Mm-hmm. So Action St. Louis, in partnership with our city defenders, recently launched the People's Plan, which is this like comprehensive policy agenda that builds power and redistributes resources in St. Louis, specifically to Black communities. Already over 30 organizations have signed on. And right now, like I want to highlight some of the healthcare policies that are being driven from the People's Plan, which is looking like increasing funding and support to provide more community health workers and community health centers, particularly in underserved Black neighborhoods, ensuring equitable rollout of COVID-19 vaccines, including public information regarding the benefit of vaccines, support full, timely implementation of Medicaid expansion with robust outreach and enrollment efforts, expanding access to safe abortions and reproductive health care, and access to inclusive sexual education programs in our schools, decriminalizing HIV status, providing and support policies that encourage comprehensive LGBTQ healthcare. And I want to drop that in the chat for folks that want to learn more about the People's Plan.
Thank you. Okay. So I'm sorry if you weren't done. Devin, can you answer the same question, but could you be a little bit more specific to like neighborhoods with notable HIV rates?
So you're asking about government policies that can improve access to high quality healthcare. Okay.
Correct.
So yeah, and I first want to say thank you to Jay for that People's Plan. That was very good. And I like to hear that ending HIV criminalization is a part of that.
Right.
But within the context of living with HIV, like there's only a handful of competent HIV providers within a geographic region. And the way that we depend on healthcare, I see my doctor once every 3 to 4 months. If there's an issue with one of those providers, I have a very finite number of providers that I can work with. So, that really gives a lot of power to the healthcare provider because I have a limited number of options. So I believe that it's really important that we are giving people living with HIV as many options as possible, and that providers are, holding themselves to a higher standard. Because again, we see a lot of people living with HIV who fall out of care for any number of reasons, but oftentimes a negative interaction with the healthcare provider. There's something about, I can't even say, but even myself, I've had healthcare providers that didn't want to listen to me. And, at a younger time in my life, I would just pop off. So that just goes to show that it can go south. Also, there's a lot of funding that goes into HIV. A lot of the times that funding is not guided by the needs of community, by people living with HIV, by Black people. I think that we need to be involved in that process at every level so that we can make sure that those dollars go as far as they can possibly go. And I also want to mention that people living with HIV have been instrumental in protecting the ACA and other healthcare legislation. We've been at the forefront of those conversations.
Thank you so much. So Jay Marie, thinking about that a little bit more critically, where do you see overlaps or points where it becomes clear that HIV is a racial justice issue?
Totally. Well, as we spoke to earlier in terms of the definition of racial justice, right? Like it is just this kind of deliberate inclusion of Blackness really at every level of care, whether that's health or policing or housing, employment, right? And so I think, as I mentioned earlier in my answer, knowing that HIV can be just thought of as a health issue, right? That's I think a lot of care providers use that as an excuse to only see someone in this very small way, right? And the reality is we need people, when we walk into that office, or in this day and age when we call or Zoom or telehealth in, we need that person on the other line to be ready to hold. Maybe there's a particular issue going on in the kind of air, like somebody's been killed, or there's a racial justice issue that's kind of come to the forefront. And we really need our providers to both be, at the top of their game when it comes to providing care, but also at the top of their game in recognizing, looking at the world around us, right, and not kind of participating in the narrative where only Black people care about when Black people are killed, right, or only Black people care when there's a particular issue in the news, right, that is really going to weigh heavy on us and really impact our health outcomes, right. But many people kind of don't see those as connected because of, you know, whatever they've been taught about what the small kind of window of health is. And so I definitely think, you know, while people might think of policing as racial justice or some of these minor subsets of racial justice, even though they're all significant, I just really implore folks, you know, like the question that we saw in the chat earlier, is there a specific way somebody could say, or a white doctor could make their patient feel safe? And it's like, you know, I want you to be confident in talking about Blackness, right? Anytime somebody comes in and they're whispering Black or whispering race to me, I already know they're not prepared, right, to talk to me about what really is going on. So that's the kind of stuff that I would say, you know, there are going to be white doctors providing care to Black people, right? But we need y'all to be on your A game. That's it.
Right. It's not the fact that it's a problem with having white doctors, but it's just psychology. Like if you see someone that you're used to, that you can relate to, you're more apt to being a little bit more open and comfortable with being proactive in your healthcare. So that's really important. So thank you.
Currently, police brutality is an issue within the racial justice movement, getting the most coverage. Where does HIV fit in this agenda? Jay Shepard, would you like to address this question?
Yeah, I think that so Black folks are extremely criminalized, and we also criminalize folks for their HIV status, right? And like you actually don't have to disclose your HIV status. Like right now, I think that a lot of times it kind of feeds into the stigmatization and the decriminalization of HIV when we, our officers are asking about folks' status. I think also like we said before when we talked about racial justice, every issue touches on the issues of Black folks' lives. It impacts the livelihood of Black folks. So when we are thinking about this movement against police brutality and this movement for the livelihoods of Black folks, like we need to be centralizing this conversation about like Black folks with HIV, positive lives mattering, right? And that we aren't all free until we decriminalize and destigmatize HIV status.
Right. Would anyone else like to add to that, Devin or J. Marie?
I was on mute. I would like to add to that a little bit, and for clarification, because you know, can you repeat the question just quickly, briefly?
Yes, so currently police brutality is an issue within the racial justice movement, getting the most coverage. Where does HIV fit into this agenda?
Okay, well, first off, I want to say police brutality is getting a lot of coverage, and rightfully so, and it's really taken a long time for that to happen. So I just want to raise the issue of HIV criminalization. We already know that Black gay men, of course, have disproportionate incidence rates when it comes to HIV. And we also know that we as Black men are criminalized. Well, we're impacted by the criminal justice system. But, you know, the public health response to HIV is huge. And when we're talking about that surveillance of Black people, that, you know, the government has access to our viral loads, to our labs, to our CD4s. There's like a gigantic amount of information that they have about us pertaining to our HIV status. And the law as it is written in the state of Missouri requires that the health department provide the prosecution with your HIV surveillance information. So that means all of those, you know, all of these labs that are run by our medical care provider can then be used against us. and it's dystopian, and it, you know, it kind of makes it difficult for us to trust the healthcare provider that we are seeing. It helps us, you know, it makes it more difficult for us to even want to engage in care. Not to mention other forms of data that are collected, such as molecular surveillance, not in Missouri, but in other regions. And that's a form of data. It's really the collection of the genetic information from the HIV genome that's used to group people according to as a similar strain of the HIV virus. And that's very scary when we consider that, you know, for one, the health department would have to give that to the prosecution. And two, you know, you have genetic evidence tying you to the next person. So that's a whole mess. But yeah, I just wanted to speak to the incredible amount of surveillance that we are subjected to.
Thank you. J. Marie, would you like to add to that question?
I mean, Devin really covered so much, and I think the only thing I would add, to be specific, I think we're going to talk more about it too as we go on in conversation, is the Missouri specific situation around really what discourages people from knowing their status, essentially, right? So we don't have up-to-date laws in Missouri. Many people live in states, I think it's about 20. Devin, you might have the number more closely reachable than me. It's like 20, I think it's like 31 states that don't have.
Half.
Yeah, so it's about half. Half states have modernized laws on HIV and half don't. And when I say modernized laws, right, I just want everybody to think for a minute about the very first time you ever heard about HIV or AIDS, right? And it was probably either in, as Devin mentioned, the lineage of protest maybe, or it was just in this lineage of gay men, this sickness. Maybe you had an uncle or an elder in your family who you found out later they had it, but there was this very kind of stigmatizing view that we used to have on it back when people were still just figuring out what to do with it and had never seen this virus and you know, this public health crisis that occurred right in the 80s. You know, the very first case was found here in St. Louis in a young person in the 70s, right? So it's got a long trajectory, but it's been a very long time because of that very long trajectory, right? And so many, you know, improvements on healthcare and on people, you know, just access to medication has been, so many improvements have occurred, but our laws are still from the 80s, right? And as you can imagine, in the Reagan years or even in the early Clinton years, right, those were, you know, super predator language, right? Those were over emphasizing certain ways of, you know, transmission. And at the time, they didn't even know what transmission really was in the range of it, right? And so one of the big things in Missouri is that we're really trying to modernize our laws because, you know, we have people that currently, if you essentially know your status and the way the laws are written right now, you can't prove that you protected yourself. Basically, they have the option of locking you away for up to 30 years, if not more, depending on what they add on top of that, right? And that's, you know, just for knowing a status of a condition, really just a kind of a disability at this point, right? As Devin said, like a chronic health condition, it almost discourages you from knowing your status, because then if you know it, they can say that you willingly did it because they don't really take any condoms or any other evidence that you protected yourself. So that's something that, you know, I hope everybody on this call knows about. And when I say think back to when you first heard about HIV, it's been a long time, right? In this case, the situation has changed greatly. So just really want to encourage folks to get more involved, and I think we'll talk more about that as we talk here today.
Thank you. So this next question is for all of our panelists. What adjustments, if any, would the racial justice movement need to make if HIV is to be successfully embraced as a racial justice issue? We'll start with Jay Shepard.
Yeah, I think that our racial justice movement could always use some support around intersectionality and the centering of Black HIV positive lives, specifically around Black LGBTQ folks. And like I was saying earlier, that I truly believe that we aren't all free until we decriminalize and destigmatize HIV status.
Okay, thank you. Devin, can you answer the question?
Yeah, so like I said, it's a really important discourse, and it's difficult to critique the racial justice conversation that's happening right now because it's so needed, but that critique is necessary. For me, the most difficult, the most challenging part, it seems like it will be just placement. Like, how do you place HIV within this conversation that's ongoing and is extremely complex in a way that honors the experiences of people living with HIV? It's kind of, I don't know how it would feel asking for this issue to be at the forefront of an already, very involved and moving political agenda. So it just seems very involved, but racial justice is also my conversation because I'm impacted by so many different forms of criminalization. And just by default, the fact that I have HIV means that my HIV status would already, further complicate any situation that I ever find myself in. So, like I said, it's just a matter of placement. And we also need to consider HIV risk that exists within, custody, within police custody. So.
Okay. Thank you. Jay Marie, would you?
Yeah. Yeah, I could totally add a little bit. I think, racial justice at this point, as we mentioned earlier, is so broad. It can include policing all the way to unemployment, all the way to just disproportionate anything that Black folks experience, and even people of color to an extent, right? But knowing that this is Black AIDS Day, we can keep focused on Black people, you know what I'm saying? And so what I would say about Blackness and kind of these overlapping points such that, we want to see HIV come out a little bit more on top. As Devin said, we can't necessarily say, don't talk about policing, talk about HIV, right? We really want to make sure that all of ourselves is included in this conversation. But what I definitely think I could see more of, and I would love to see more of, whether folks are Black or otherwise, supporting movements, right, and you're not Black, is a boldness, right? So one of the ways that I would love to see that is my work at this point has become more about, in my work on trans folks and supporting and finding trans justice, achieving that, we're starting to talk about sex work, right? A lot of people may not even know what that refers to, right? Because they might just think of the term prostitution and not have ever heard the term sex work, right? But the term sex work really kind of elucidates that it's work and trading for pleasure or services, right? And so if people aren't willing to talk about some of these issues that may have historically been more taboo, or you just don't have the latest terminology on it, that's going to be, impacting how you talk about the rest of what people care around, or how they can kind of have their needs met, right? If somebody can't come to tell you that, yeah, I've done sex work before, and whether or not that makes things more complicated in terms of their healthcare or just in terms of even their employment, their housing, we want to be able to talk about all of that. So I would just love to see a boldness in how people talk about and take care of their patients, clients, and even just comrades in the movement. I want you to be a more confident repository for somebody to tell you their full experience, such that you're not interceding or interrupting their care because of your biases or because of your lack of work. And I encourage people to go to, it's very similar to the link that was just put in the chat, and so I won't write it yet, I'll write it in a little bit, but MoHo Justice is a coalition that I've worked with here in Missouri broadly, that is trying to, find more justice for hoes, because not everybody is in sex work out of coercion. Some people do it because it actually makes more money than the nonprofit industrial complex, and it makes more money than their grad school experience, right? So we want people to have the tools, and we put out a report in the fall, really in December we launched it, so you can look at it, mohojustice.com, and that'll really get you kind of started on that journey, for example.
Right.
Thank you.
Thank you for bringing that up, because that does play an important part with HIV as far as, it being a racial justice issue. I can even account for the experiences that I've had just being not only a Black man, but being a gay male as well, and positive. So those are a whole lot of intersectionalities in its own. But just to go forward, are there currently any efforts in Missouri to better integrate HIV work into being done under this racial banner? And if so, how can attendees participate or even get involved? And furthermore, is there any updates on any call to actions brought forth, even by the Ferguson Commission? And I guess we can start with Jay Marie.
Yeah, so, the number of recommendations in the Ferguson Commission, I can't say I've memorized them, but as somebody who has been doing this work for a decade or more, I would say the main things that I would just really encourage folks to have on their radar is the Mo HIV Justice Coalition that Demario put the link to in the chat. That is an incredible powerhouse of a group that not only put on today's panel, but for example, this coming Monday, a week from today, is going to be testifying in support of getting our modernized HIV bill across the finish line, right? So it's got a few more steps, but we really, 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 if there's nothing else that you get off this call right now, these 50 people on this call, I would really ask that you all prioritize what might be the unsexy part of making change, right? Which is the calling your legislators, writing to people who are at the state level, especially because, we have our citywide issues, our frustrations on the local level definitely are real. And sometimes what happens is because we're so frustrated or annoyed or just trying to live in our lives on a daily basis in our city level, we forget that the state is where, they're introducing bills like you should be able to hit a protester with your car, or, you should be able to get fired, and all these other things that become kind of things that are on the line when we fight for our rights, right? So just this Monday, this upcoming Monday, we'll be doing some committee work at the State House, and a lot of that will be virtual, of course, but really, really, really want folks to find themselves, heading to that link in the chat right now, mohivjustice.org, look around, click around, understand kind of where you fit in the issue. And, the group meets a couple times a month, but we, more broadly are trying to get more people involved, whether you come to the meetings or not, able to quickly respond when something needs to happen, right? Because this bill is super close to getting over the finish line, and we really can't do it without people who understand how big of a deal HIV is, not just as a racial justice issue, but just in the lives of all of us. We deserve safety and access to healthcare and modernized laws.
Definitely. Could you elaborate, Devin? Add to it?
Yeah. So there's a few organizations throughout the state. The first one that comes to mind is like Williams and Associates in the St. Louis area. And I believe there's a few other Black organizations that are focused on LGBT health and HIV. Also, there's a Blackout KC in the Kansas City area. And one thing that I feel like is critically important to all of our work as it relates to HIV is MIPA. MIPA really comes out of the movement for people living with HIV. MIPA is a set of guidelines, guiding principles that help you to ensure that you are centering the voices of people living with HIV, and that includes practices like not having a meeting before the meeting, and making sure that people living with HIV are represented in monitoring, planning, implementation, evaluation of anything regarding HIV. All of those things need to be accountable to the people who are served and the people who are most impacted. And like I said, protest is really at the heart of the movement. So when we're engaging people living with HIV, like on planning councils, we need to be prepared to increase the capacity of people who are there. We're not just there to to sign off on whatever you want us to do. We really have, we need an agenda that will best serve our people. So that's all.
Right. Jay Shepard?
Yeah, I want to uplift all of the orgs mentioned. Definitely want to uplift Moho Justice that Jay-Marie's been doing a lot of work around. You still got to drop that link in the chat for the people. Want to uplift the People's Plan, as I did earlier, with this comprehensive policy agenda, as we are calling for the decriminalization of sex work and decriminalization of HIV.
Alrighty, all right. So I guess we can open this time up for any questions. If anyone have any questions, I'm going through the chat now. I see Bree says so much around HIV has evolved through the years and laws are stuck in decades ago. And that is true. You're a person that's positive and you spit and you're around someone that is negative, if they wanted to, then they could definitely call the police and feel like they were exposed and you would have to fight for your rights or your life. So that I feel personally they should go ahead and update these outdated criminalization laws to today's reality, because of course, as we all know, there's U equals U out there, undetectable equals untransmittable. a person is taking their medication for 6 months, and they are adhering to their medication, there is no possible way that they can transmit it. But this is the type of education and literature that is not in the communities that's needed. And this is why we need people that can get in these grassroots programs or organizations with us to get the word out there, because it's all up to us. We all are family at the end of the day, and I feel like as humans of human beings of this, you know, reality and earth, I think it's our duty to help each other and uplift each other. But of course, like we said today, you know, we have the statistics shows African Americans are most definitely disproportionately affected by HIV. And with this epidemic they got coming out between 20 and 30, in order to get this completed or even addressed, we have to literally incorporate innovative strategies to get our community, African American communities, involved, not just going to the same TGA members or going to the same people in the same you know, career that we all used to. We have to really get out in the grassroots and get this educated to the people in our community so they could be aware. We have hotspots in KC since we're one of the states that's being targeted, or I don't want to say targeted, but that's identified to end this epidemic. These zip codes with these people with these high rates, they should be informed. They should be knowing about what's going on and how this is a public epidemic. So again, I appreciate everybody for coming. Reach out to any questions. I see J. Marie put for the report on sex work, which discusses penalty enhancement for sex workers living with HIV. Is that the, I believe the link she put below it?
There is, excuse me, there is a chat from Annie Calloway. Are there specific ways, something that could be said or do a white doctor could make their Black patients feel safe? Or is the only solution pairing Black patients with white doctors? And then she put Black patients with Black doctors.
So, okay. So, I don't like that framing because it kind of assumes that if a Black patient is with a Black doctor, that they're automatically going to understand, that they're automatically going to understand the experiences of a Black person. Well, that they're going to be less racist. I'll say that. And we know that the implicit bias test tells us that Black people are equally as prejudiced against Black people as white people are. So I don't like that underlying assumption. But we do need a healthcare workforce that is equipped with the skills to work with Black people. And, you know, and there's a power dynamic. Be prepared to address that power dynamic. You know, people who know me know that I've worked in the healthcare field, and we all know if we work close by that there's some inappropriate things that happen. So make sure that our providers are professional and that they're appropriate and that they are polite.
But accountable.
Yeah, I mean, we have plenty of experts. Dabari, you're an expert in this area also. So, I mean, I think there's plenty of voices that are saying what we need. Maybe we can.
At the end of the day, it's bedside manners is what we always refer to. You are still dealing with I don't want to single out because, you know, you're dealing with a group of people that's still coming in to get healthcare. And when you have people that have implicit bias, then they have one way of thinking. They don't understand the power that they have for making people not want to get in care, not want to be associated, not want to deal with it. You got to look at the medical mistrust in the African-American community. We still have residue left from the Tuskegee experiment, and people want to dismiss that and say that it's a long time ago, and it's still prevalent in different areas of the healthcare field, but it ties within HIV as well, because that is a healthcare need that African-Americans needs to have addressed to this day. So
Demario, for example, we can go to a doctor and say, you know, there's something wrong. I need this issue addressed. And they'll come back to us and tell us, no, this is what it is. It's not going to go away. You'll be fine.
Pain management, for example, a lot of, you know, I've seen just dealing with the clients that I deal with, because I work with a lot of population that's homeless, that has been marginalized, that's just going through a lot, substance abuse, but they really do have pain and things of that nature. And they go to a doctor and they're automatically deemed as a what they call a medication seeker or something of that nature. And I know for a fact, educating these clients, being with these clients, being at the hospital with these clients, going through procedures with these clients, I mean, going to the homeless shelter, everything that I know that they actually needed, but it's somewhere within the health system, and I want to say in the hierarchy where they feel in some instances that they're pill surfing, and sometimes that's not the case. And a lot of these people, they fail, and I've lost 2 people that I've personally worked with due to neglecting things like opioid treatment and substance use.
So we have Russell has his hand up. So go ahead, Russell, with your comment or question.
I just wanted to kind of follow up with what Devin, along the lines of what Devin was saying, because I'm trying to figure out how to unraise my hand, is that it's not just white doctors that were trained in this way. Mm-hmm. So it's across the board. The medical mistrust, and please correct me if I'm misspeaking, but the medical mistrust is not necessarily because the doctor's white. However, a lot of the education came from white doctors. Mm-hmm. But we now have all of these other educated men who have become doctors across the board, people of color, people not of color, that have done the same shady ass shit. Just to put it out there. So, and even in my own life, like living with HIV is a big deal. And when you feel like your doctor doesn't tell you, as a white man, I can tell you, I'm sorry, but I don't think you heard me. And I can get away with that. So because I have a light skin tone. But when you tell me, and I've got to also have a loud voice tone, you're going to listen to what I said because you're not listening. So the rest of the community with, darker skin may say, well, okay.
So I want to say that part of that, the part of that I can relate to is just as people living with HIV, we always have to make space. And sometimes we have to do it in a way that's not tactful at all. So I can definitely relate to that aspect of what you're sharing. And that, like I said, I was saying that HIV is kind of like a disability movement. What I mean by that is that we need to form our own networks, our own communities, so that we can show that we are capable of making decisions for ourselves and that we know what quality care looks like. We need to be engaged in those conversations.
Right. And just to furthermore expand on that, Russell, I agree with you that it's not only white providers, but at the same time, when you think about the African-American, people that are coming out of college, what opportunities do they have? And even the things that they are taught, how are they able to even get into real time or into these communities to see that it's different from what they have learned? So at the end of the day, it's still access to being able to, you get what I'm saying, relate to the same type of provider, because it may take someone, African American or Black, to be like, hey, you've been saying this and this is what I've been experiencing, you might want to. But if they don't even have access to that, even if they do or don't know, but if they're not in the community and the people that need the service, or even the providers, if it's not there to present itself, how can we even address that?
So I'm going to add up with you, Demario. I'm going to put this question out for specifically from the perspective of people of color. Please tell me, as a white man, and I've said this across the board, you've heard me say it before, what it is that I can do to help train and help facilitate other white folks to see a different perspective.
Right. Well, I think you're doing enough by being here.
But not everybody. I think I'm, how do I put this? I think I'm blessed with a different perspective.
someone to mute, please?
Jennifer Harris.
Mario and you should be able to mute folks. Is that possible? There we go. It might also be a Zoom bomb. You might have to remove somebody from the room.
Yeah, they're intentionally unmuted.
Can we please have you mute? Stay muted.
Sorry, I had to remove that person.
Yeah, no, they're not. Yeah, they weren't coming in good faith. So, thank you to Mario. But was somebody going to answer? I don't know where the stage of the question was at that point.
I'll just say this, and then I want to ask that our moderators in the webinar. So I think that Black people have always been talking. I don't think that we've ever stopped talking and explaining what it is that we need. I know I, for one, have not stopped. What I feel like our community needs, and I'm speaking as both a Black person, Black gay man, and a person living with HIV, is we need, we need to be included in every part of the process. We don't need allies to speak on our behalf. We don't need allies to do our training. We provide training. And it's also appropriate for us to be compensated for our labor. So yes, the best thing that we can do is we can empower Black people, put us in a position to lead, and make sure that you listen to us when we are in charge, because we are the authority. We're the people who are most impacted. Yeah, amen.
Well,
yeah,
that's it. I appreciate the conversation. I would like to extend more time to, but unfortunately, we do got to wrap up, you guys. Russell, I dropped
a link in the chat too for you to study at Russell. And the general kind of check your privilege work, like if you look at Instagram, check your privilege account is one place to look, just to do that kind of regular living into the work, everyday work. And I understand that I'm sure you were coming with your best intentions,
Yes.
but of course, unless there's that relationship with folks, and as Devin said, it can be difficult when there's no payment involved or other things that help people understand you're coming in good faith. So I don't know you, and I'm not interested in you having to respond and situate your case. But I do think there are many people on this call who might have a similar question. So I encourage you all to look at that resource. From the Black AIDS Institute, to follow the Mo HIV Justice Coalition, to follow the Moho Justice Coalition, to follow Action St. Louis, to look up the People's Plan. There are so many resources that have been named in this call alone that really are less about only kind of singular issue work, and also about just expanding your commitment, because when you have an expanded commitment, questions don't even come out like that. You're already doing your work, and you are in relationship with people who are also doing their work. So you don't have to come to us. You will be able to come to your colleagues, your comrades, who will keep you on that journey, and we will trust that that work is being done without having to kind of be situated as the teachers. Even though we are teachers, it's a difficult balance, but I trust that you can find it.
Absolutely. That was my reference to that, is that I may ask that question and hear it in the way that it needs to be heard, but I ask that question in reference to other people.
Right.
Okay.
All right, we're wrapping up. Thank you.
Thank you,
Yes.
Russell. Appreciate
So
that.
I would like to thank everybody for joining our event today. And I would like to give a special shout out to our sponsors. Our sponsors were the Black AIDS Institution, Missouri HIV Justice Coalition, and the Reproaction. The Reproaction doesn't have any upcoming events, but you can keep up with them and their work by visiting their website, reproaction.org, and signing up for their email list. You can also follow them on social media at Reproaction on all major platforms. Kevin, would you like to provide the audience with any upcoming Black AIDS Institution events?
Thank you, Kaya, and thank you, panelists, and thank you, Demario, and Devin, and everybody that's been involved. I think this was a great conversation. I don't have anything really to add. Just I would say go to blackaids.org to find more information about the Institute and our work, and definitely for the folks that are in Missouri, the Kansas City area, St. Louis, the B10 chapter, they're doing some amazing work already in Kansas City. They're one of our newest kind of affiliates, and fast-tracked themselves to be a full chapter. And I'm looking forward to continuing to work with them. So yeah, I don't have anything really else to add, but I would say good job, folks.
Thank you.
Yeah.
Thank you.
If I could just add real quick, if anybody's interested in HIV criminalization in Missouri, feel free to visit our website, or you can email us at MissouriHIVjustice@empiremissouri.org. Missouri HIV Justice is a coalition of groups and individuals working to change outdated and stigmatizing HIV criminal laws in the state of Missouri, which is a project of Empire, Missouri. We have a legislative committee, we have a media and messaging committee, and education and membership. So again, we appreciate you guys for joining, and big, huge shout out to Reproaction Eva, Miss Woods. Thank you so much. This wouldn't be possible.
Yes, thank you, Eva.
Thank you.
Thank you, Eva.
Let's have a good
Thank
day.
you to our moderators.
Not
Good work,
this
y'all.
month.
Thank you.
Be safe out there.
History Month.
Everyone.
See y'all later.
Bye.